having been trained under the nursing model, they're more holistic. They
Mm,
focus on kind of the treatment of the patient with the disease versus what of the disease. I always say it's like a caring before curing mentality, and that's really different than the way physicians are trained, which is more under a medical model. Both are important. I'm not saying one is more important than the other, because healthcare is a wheel with a lot of cogs in it, and you need all of it
right.
to go around.
Hi, everyone. Welcome back. I'm Sonika Garcia,
And I'm Brad Davidson, and this is Breaking the Code,
a podcast series addressing misconceptions related to the discipline of behavioral science. We hope to arm you, our listeners, with the tools you need to make sense of behavioral science and to help you apply it to your work as communication extraordinaires. Thanks for tuning into episode 31 of Breaking the Code. As you all may know or may not know, March is Women's History Month. March 8th was International Women's Day. And so we knew that on this episode in the month of March, we wanted to honor women in some way and the history of women and the evolution of women in healthcare specifically. So for today's episode, we are going to be focusing on nursing and nurses as it relates to the work that we do in healthcare communications, how the occupation has evolved over time, where it continues to head in the future, and how we can do a better job in our role in making sure that we are providing resources to nurses. You know, a lot of the materials that we create are obviously for patients and then for HCPs or healthcare providers. As we bucket that group, we usually refer to HCPs as doctors, and we use those two terms interchangeably, but we do know that nurses are very much so healthcare providers as well. So thought it would be a really great opportunity for today's episode to get into nursing. And obviously, what better way to do so than to speak with a nurse than someone who has the experience and also works in healthcare communications. So we are so honored and excited today to have a very special guest on, a dear colleague, Havas's very own Lisa Chobanian, who is a nurse herself, as I mentioned, and she is also a Havas employee. So, Lisa, thank you so much for joining us.
Oh my God,
We're
thank you
so
for
excited.
having me. I am
Yes.
so excited. I listened to you guys, and I can't believe you asked me to be here
Uh,
and to focus on a topic near and dear to my heart, nursing. So thank you.
Amazing. No, thank you. And so I'm going to try to do your intro justice, but you know, there's so much experience. We're so excited and grateful that you decided to come on. So thank you. So Lisa is an associate managing director at one of our agencies, H4B Chelsea, and she has been with the Havas Network for over 12 years. She is both a registered nurse and a registered dietitian, and has really been able to bring her nursing experience to great use on the agency side. She has helped lead NP practice dedicated to initiatives targeting nurses and practitioners, developing materials geared toward the nursing audience, which again is so needed and something that we need to be talking about more in our industry. Lisa started her career as a pediatric nurse in the Children's Hospital in Boston, where she gained experience in many different areas, including medical, surgical, and oncology. So obviously, such a depth of experience on the nursing side, such a depth of experience on the agency and communication side. So honestly, the perfect guest to have on.
You're too
So
kind.
again,
I don't
thank
think
you.
we're being kind enough, right? I
Yeah,
mean, let's hooray for the
literally,
nurses,
like,
right?
all right, yeah. So let's jump into it because we want to talk about a lot.
Well, Lisa said something. She said something that's near and dear to my heart. So, first of all, I just want to shout out the three most important nurses in my life: my wife, my mom, and my aunt. Nurse Atkins, Nurse Ottinger, Nurse Davidson. Thanks for all you do. And then Nurse Chobanian. Why don't we just start with the first thing you said, which is it's near and dear to your heart? What do you think it is about the culture of nursing that makes nurses so strongly identify with being nurses?
I think, it's a combination of why you go into the field as well as the training. So I think you almost have to self-select to want to help people, because nursing is such a personal profession. Like when you're dealing with patients at that moment and some of the things you do in caring for them, it really the hardest or sometimes lowest points in their life, it is so personal and it's beautiful in a way. So I think, based on the training, you learn these skills, how to listen and care for people. But I also think innately, it's why a lot of reasons people choose nursing because they want to help people. So that's the kind of thing that for me makes it so near and dear to my heart.
I've worked with you a long time. I've always appreciated the perspective you bring, and something that we both talk about a lot is every time we put nurse tactics into a brand planning or something like that, it's usually the first thing cut, and people are like, "Well, we
Yeah.
wanted to do it, but we can't." It's like I feel like that's the history of women in medicine. Like, well, we'd love to get you a pair of scrubs that weren't pink, but it's all we've got, so wear them anyway, right? Something like that, and I feel like nursing is really coming, I don't want to say coming out of the shadows. Everybody knows that nurses exist, but I feel in terms of the role and the importance of nurses in the delivery of care is growing exponentially. Certainly, there's been a lot of talk around the nursification of primary care, for example. There's a shortage of primary care physicians. We are filling that shortage with nurse practitioners. There's just a shortage of healthcare providers overall. And in many ways, nurses are really being used as the oil of the machinery, right? Like that, they're the ones who make things go round. So talk about sort of the emerging role you see of nurses in this sort of evolving healthcare landscape.
Yeah, I mean, you're right, Brad, in that, we can't ignore nurses anymore and some of the materials we create, and we can talk about that a little bit more. But I think the state of nursing right now, it's really at a tipping point, and this probably started, 4 years ago with COVID. Even before that, the nursing profession had major issues, but the pandemic really tested and strained the healthcare system to crisis. And COVID caused like major burnout for the whole healthcare profession, but especially for nurses. They were working double, triple shifts.
Yeah.
Their lives were in danger. And because of all that, a lot of nurses are leaving the workforce and more now than ever. And it's not just those that are retiring and getting older, but it's like nurses under the age of 35. They've kind of had it. There's patient dynamics, there's insufficient staffing. Like I know when I was a nurse during day shifts, we had like maybe 5 patients that we took care of. But now nurses have the whole floor and they have nurses' aides to do some of the other things, but a nurse can't be in charge of the whole floor and do a good job. And that's frustrating. And you're not helping people at that point. So I think some of those things, having to do double shifts, the fact that they're not safe with COVID, all of these like dynamics have really led them to consider career shifts, retiring. And it's really quite a change now. But, the good news is I think all of this is causing some changes in the profession for the better, hopefully. There's now, they're looking at it so that nurses, especially if you're an RN, there's a shift towards more BSN degrees, which is a Bachelor of Science in Nursing, which I think for RNs is a good thing. I mean, that's how I studied, and I'm a fan of that because, you're doing a lot of things in healthcare. And to your point, you're the oil of the machine. I think as Brad, you've said before, it's a team sport, and nurses are kind of like, one of the quarterbacks on the team to make sure that everything goes around, and
Yeah.
hopefully there'll be some pay increases too for nurses.
Yeah, hopefully there will be, right? I think staffing ratios is something that nurses continually strike on. What you're talking about. I think, 5 patients per nurse would be a dream for some of the nurses I know. The amount of work and throughput that they're being asked for is tremendous. But, nursing has always had this sort of dichotomy with doctoring. And one of the biggest dichotomies during the pandemic that I saw was you can't nurse remotely. Nursing is a hands-on job. And we knew a lot of doctors who were doing a lot of remote consults, but you can't do remote nursing. Yeah, not for most of the nursing that gets done. And that I think was underappreciated when people went, how is a garbage man or a deli worker or something like a critical employee? How come they have to go to work? It's like, because you can't do them from your house, you have to be on site. And I think people didn't really appreciate the degree to which nurses were throwing themselves in the front lines. They're truly the frontline healthcare worker.
Yeah, great point.
It's such an important distinction, I think, between nurses and doctors. And we saw that during the pandemic. And I think that's to my next question is, they are, the roles are so different. Functionally, the way that you were, trained is obviously different. So I would just love to hear a little bit about, like, what does nurse training look like? How is it different than the way a doctor might be trained? Would love to dig into that. Because I think if we're thinking about, okay, well, we want to create communication for nurses and really understand the occupation better, we need to understand, how are they trained and how do they come into being the way that they are?
Yes, Anika, great question. Let me see if I can break that down because there's a lot in there. So
Yeah.
a nurse is not a nurse is not a nurse. So there's LPNs, there's RNs, there's, nurse anesthetists, there's nurse practitioners. So there's different training with nurses. So typically, I mean, I'm going to focus on like RNs and NPs, but there are a lot of different types of nurses in training within that. So in terms of like RNs, the training, you do some undergrad degrees, obviously, in science, and then you have practical programs where you're literally working in the hospital. And interesting right now, like that is one of the challenges. There's not enough faculty to train nurses,
Yeah.
to go up there. So
Right.
that's an interesting level, but it's that practical experience. Like I remember in college, we'd go out the night before to parties, and then at 6 a.m. I would have to go do a rotation in a hospital. Like we had a very different type of training than other folks in college. But with NPs, what's so interesting, NPs are really trained differently. And this is why I always, tell people nurse practitioners are different than PAs. PAs are more like trained like physicians, and NPs really they're nurses first. So NPs attend nursing school, just like, an RN. But they also go through a doctorate level in nursing where they get this advanced clinical training above that, what's required for registered nurses. And so based on that, then they can be prescribing nurses. But having been trained under the nursing model, they're more holistic. They
Mm.
focus on kind of the, treatment of the patient with the disease versus what of the disease. I always say it's like a caring before curing mentality. And that's really different than the model, the way physicians are trained or PAs are trained, which is more under a medical model. Both are important. I'm not saying one is more important than the other because healthcare is a wheel with a lot of cogs in it, and you need all of
Right.
it to go around. But it is a very different training, and I think a lot of pharma companies and a lot of agencies and a lot of people just say, well, let's lump, NPs and PAs together
Yeah. I,
and
Yeah.
let's, call them the same thing.
Yeah.
I mean, I want to underscore that one because that's something that I've worked on a lot, where in as much as certain brands will look at what they call advanced care practitioners or mid-level, I mean, there's even an argument about what to call them. I did
Yeah,
a
do not
study.
call them that, but we can get to
Right,
that.
exactly. Like there's no really agreed upon term for NPs and PAs, but when you lump them together, you sort of obliterate the fact that NPs are nurses. And so there's a number of different facts that come with that. One is, as Lisa said, you start right at the bottom of the nursing ladder and you climb your way up. And I don't mean that in a bad way. I'm just saying your first degree is a stepping stone for nurses. For PAs, it's the degree. You start PA school, you end PA school, and you're a PA. What's interesting to me about nurses and nurse culture, and something that I think is underappreciated, and Lisa even touched on it when she was talking about RNs and LPNs, is how many types of nurses there are, how different the training is, and how nurse culture is really a very pro training and pro certification culture. When you go to doctors and you say, we'd like to train you on something, they go like, Duke Medical School trained me. You can show me something new, but I'm already trained, right? Nurses don't really react that way. Like for nurses, every degree you get is more money and more autonomy and more ability to help patients. And so as you watch nurses go through their career, most nurses continue education to try and get to the next level. And that's something that, as a company that creates materials that we want people to look at and learn from, nurses are a very ready audience. They've got means, motive, and opportunity, in some ways much more than the other clinicians that we try and sell ideas to. So that's like one key idea coming out of this, I think, is nurses are hungry for training. They love to learn new things. It's both rewarding professionally and personally, and in many cases financially, to do so. So we should really have a much bigger like eye for that kind of material, I would say. I mean, Lisa, again, statement in the form of a question. Would you agree?
1000%. I think, just when you look at even just from the perspective of the profession and getting a degree, even doctorate level nurse practitioners that have prescribing authority, they get different certifications after that. So for instance, they could be a women's health nurse practitioner, or they could go into, oncology. So there's always this quest to learn and do more and hungry for things. I will say the other thing is nurses are very appreciative when you create materials for them, by them, and specific to them. You will get return 1000% because they so appreciate that. They just want to be seen and seen for who they are, just like
That
anyone
Yeah.
else.
that is so important. I think that that's like, yes. And something and I have a million questions related to that, but something else that I thought was really interesting that you touched on, and we've kind of categorized it a different way, but it's essentially saying the same thing. We talked a lot about like disease versus illness. And so I think when you said, they're treating the patient who's living with a certain condition, I hear that as they're treating the illness, they're treating the experience of living with something, and what that means on like your quality of life and your day to day and how that really impacts. Whereas sometimes doctors are treating, I mean, they do treat that as well, but they are treating the actual disease and, the cure over care, it just, if you like compare the side by side. So what I think is really interesting about that is I know in our roles, we talk a lot about like, well, what's the emotion that we want to highlight that a patient is going through, and what are their emotional needs? And like, besides just, yes, having this treatment, how can, the brand solve for impact their emotional needs and their impact on life? And like, what does it really mean to be living well with the condition? And it feels like that's very related to what nurses are interested in their role. And so if you could just talk a little bit about, I think we can all agree that nursing is a little bit more emotional, has more of like of an emotional role than maybe a doctor. But is that accurate? And how does that kind of look like in a
Yeah, and
clinical setting?
for sure, and great points. I think, when a physician has, as they say in primary care, 7 minutes with a patient,
Mm-hmm.
how are you going to be able to focus on everything? You
Right.
can't. And so that's why that model of like having nurse practitioners, and they tend to spend more time with patients and just, because they can. And because of that, and based on their training, you really are able to look at holistically, look at, family, the support system around them, any kind of healthcare disparities. And not that physicians are not doing that. I don't want to give the impression they're not. It's just the nurse has more time to explore these areas. And again, based on that nurse training in terms of really understanding the emotions of what the patient is going through, how hard it is for them to live with the disease. Do they have transportation to get them to places? The
Mm-hmm.
reimbursement, like a lot of times, the office nurses in a lot of places are actually the ones having a fight with the insurance companies. So they're closer to some of the things that the patients are dealing with on a day-to-day basis. And I think as we, consider developing materials for nurses at our agencies, I would just urge people to really look at the audiences differently, and also look at the nursing audiences differently, because there are
Right.
prescribing nurses and then there are non-prescribing nurses. And the non-prescribing nurses will really be good for things like, injection training and infusion nursing and adherence and counseling to patients and what to look for in terms of side effects and when to call the office. Whereas on the NP side, these are prescribers. And, you mentioned this idea of the nursification of primary care, but we didn't really get into the field of primary care and the fact that medicine is not going to be able to handle the need for primary care with physicians in the future. So NPs are going to be taking over a lot of primary care. And you see that in, the CVS Minute clinics and urgent cares. And even when you try to get an appointment,
Well, me,
at
yeah.
your provider, a
I
lot of
my
times
so
you're
I
going to see an
switched.
NP.
Yeah, I mean, look, I think the future is here when it comes to like the shortage of primary care. I live in the Hudson Valley, and I had a different primary care doctor every year for like 7 years at the same health system. And finally, I was like, just give me an NP. And now I've had the same NP, and it is a woman for 8 or 9 years now, and it feels much more like those old relationships that people would talk about where, Doc Jones, the local primary care guy, delivered a baby of a patient that he himself had delivered 20 years earlier or something like that. Like this nurse practitioner now is my wife's nurse practitioner is, as my kids come back from college, they'll probably join up. Like it does feel much more like a nurse is in the position of that old trusted family doctor. And that's exactly how I think of her. And, I think there's a push and a pull there. The push is we need more primary care providers who can just do basic primary care. And I don't mean basic as in simple. I mean as in the routine stuff that everybody needs, birth control and blood pressure pills and all that sort of stuff. Like that's really the frontline clinician's job. And we don't have enough primary care physicians right now. So the push is we need more NPs because they need to fill that. The pull a little bit is they're cheaper. That's one of the sort of like dirty truths that we either talk about or we don't. But the reality is nursing is overwhelmingly female. It's also, there's a strong belief that it's overwhelmingly underpaid. And when you look at sort of where nurses are, and when you look at even doctoring, which is 50-50 male female now, but it's not evenly distributed, women over index in primary care, pediatricians, OBGYN, those also have had sort of wage erosion. It's hard not to look at the landscape of healthcare provision and see that the female dominant specialties are lagging behind in terms of wage. I think there's a real challenge in that the women who are providing care are routinely being underpaid. I don't have a great solution for it, but I just don't want to not call it out. Like that is something that is a big topic of conversation in the
Yeah,
nursing
no,
world.
it sure is. And, as usual, you bring up a lot of good points in there. So let me comment on a couple of them. First, in terms of the pay disparity, that's absolutely right. And what's sad, even though there are more males now going into nursing, it's still largely, dominated by females. However, there is a pay discrepancy, not only in nursing as a whole, but in those nurses who identify as male. They report higher salaries than those who identify as female, hoping that the whole nursing profession will see increases as supply and demand can lead to pay increases and then more education requirements for that. So I hope the trend in the future, there'll be more, increases for that based on that. And also, looking at the disparity between male nurse and female nursing. You also brought up, which I love, that idea of NPs kind of taking over the, old family doctor kind of thing. And I think what a lot of people may forget is NPs have independent prescriptive authority, and
Right.
they can treat and prescribe independently of a physician. PAs, although that's changing and COVID, made it more that way, a lot of PAs still are under a physician. And I think as we look towards, you know, creating materials for prescribers and marketing our drug and creating educational materials, nurse practitioners become a very important audience. And it's not enough anymore to just take the materials you create for, a physician and just do the same thing for nurse practitioners. I think you're going to get more bang for your buck if you really tailor it differently. I mean, again, we've talked about the caring versus curing. We talked about the fact that they're with the patient more as nurse practitioners, giving them materials that allow them to, how do I talk to the patient about this particular therapy? What are some key things? Are there handouts to give them and their family? These are the kinds of things, in addition to the typical, safety and efficacy data and appropriate patients, that they will need. And again, when you tailor things to them and you see them, they are so appreciative. There's a huge opportunity for us to do things with nurse practitioners.
I love that. And I think it was a point that you made earlier. That's a really important one. And it's that, like, not only to create the materials, but to work with them when we create them. I mean, like, just even
Yes.
hearing you say it is very validating. But then, yes, when we go to actually then create the solutions, we often do it in like what we think they need. And yeah, while we might be, 40% there, it's important to co-create with them.
What's frustrating is I think a lot of times people guess.
Yeah,
They
it's
wouldn't say
guessing.
they're guessing, but I've been in the room, and I'm sure Lisa has too, where people have said like, well, let's just make it for nurses. And then they just start speculating wildly about a field they don't really know. And so, for example, something that Lisa brought up right at the beginning, and she's sort of boiled it down to care versus cure, but it's much more complicated than
Care
that. There
before
is
cure.
care before cure, right?
Yeah.
Sorry. Right, exactly. They're both about caring and curing, right? But the nurse approach is a named thing, right? So as anthropologists, we get interested in things that not only that we discern, but that the subject of study, and I'm putting big air quotes around that, right? But if you're studying nurses, one of the things you notice very quickly is they talk about the nursing approach, right? They talk about how nurses work differently. It turns out that comes from their training, which is different. And when you go through nursing school and you're writing papers, you're supposed to cite nurse written papers, not doctor written papers. Look, in part, that feels like to make sure that nurse academicians get their due, but in part, it's because they approach it differently. And so if you're just going to scratch out doctor and put nurse, you've missed the entire thing that they're really trained quite differently, and they come out of a different history, and they view themselves differently. And in many ways, nurse education is much more flexible, much more open to evolution than doctor education. So personal history, my mother was the first class, I believe, of nurses to come out of the university setting, as opposed to just floor nursing, so just hands-on experience. And it was an interesting experience for her. The older nurses sort of resented it a little bit, but also it was a shift from, learning on the job to learning in the classroom. And
Yeah.
this, she's been retired quite a while now. I'm not going to tell my mother's age, but nursing training continues to evolve. We have nurse anesthetists now. We have lots of specialty nurses taking over procedural roles. We have lots of different nooks and crannies in hospitals that are just jammed full of different types of nurses. And we cross out doctor and go, they'll use it, they'll be fine. That is, to me, such an overlook, such a miss.
Yep. Totally agree.
We should go start an agency just focusing on nurses, Lisa.
No, why not?
Well, as I said, it's at H4B Chelsea, we, have a practice dedicated to nurses where we try to help our clients see the difference in these audiences and, consult and help to develop and tweak materials. I mean, here's another thing that like is just such an easy fix. I was, watching your typical DTC commercial, and of course it says, call your doctor, ask your doctor, and just let's change some of that, change
Yeah.
it to ask your healthcare professional. Like, it's not always a doctor who's prescribing your medication. So there's a lot of
Right.
opportunity out there.
I
It,
agree completely. And when you look at things like prescribing, it's NPs, right? But when you look at things like adherence, or like you said, like, persistency, adherence, just showing up to your next appointment, that comes down to the people you interact with, not in those 7 or 11 minutes of the sort of jam-packed sort of diagnostic, the clinical interaction, focused around the doctor or focused around the primary caregiver, the frontline primary care. But all the other people you talk to, many of them, unless they're just, and I don't mean just, but I'm saying unless their only responsibility is scheduling, pretty much everyone you come across behind the front door of an office is a nurse of some sort, and they have responsibilities to the patient. It's not just administrative. It's literally they're the relationship in many cases with a chronic disease patient. The doctor has one relationship, but the staff has another one, and it's critically important. And it's been shown again and again and again in studies that if you want patients to stay on therapy, they have to get along with the office. They have to feel like the office cares about them. These are tangible outcomes. These are not, sometimes culture gets boiled down to like it's touchy-feely and we can't really define it. We can absolutely define it. If somebody walks out of the office feeling angry, they're not coming back, right? Like that's very easy to define. If somebody feels like no one cared that they had a bad experience, then they're going to sue. And what they have found is all it takes is a nurse going, I hear you, I'm going to make a note of that and we'll do something about it. That's all you need to do. Somebody feels heard, right? So it is material, not just sort of emotional, the difference in how people feel about the experience they have in healthcare. And it comes down largely to the quality of nursing.
And that's true not only in offices as you're talking about, but even more so in a hospital setting too.
Yeah. Shout out to the acute care nurses on I won't name the hospital or floor, but with my wife. So yeah. She's asked me not to bring her into this one, so I'm just gonna back quietly away.
Lisa, I'm just
Yeah.
curious, have you been met with resistance or or what are some of the challenges that you've faced when you're having those conversations with clients on like creating, the importance of creating material for nurses, just, to help arm, our listeners with like discussion points or considerations, because I think it is really important, but I'm just wondering if that's been challenging.
Yeah, great question. And I think, one of you brought it up earlier. So, usually as we go into clients and we kind of share some of the stats and rationale behind why target this audience, you see a lot of head nodding.
Mm-hmm.
I think the biggest resistance is always, I forget who said it, but like when there's a budget cut, this sometimes
Yeah,
is the first thing to get cut. I
right.
think what's important to try to do is not to just educate on the role of the nurse, but find something specific. So
Mm-hmm.
like as you're depending on, for instance, if we're targeting HIV and going to clients that have HIV products, for instance, we found an insight where there was an article that showed that, nurse practitioners are more likely to prescribe a PrEP than a physician. So
Mm-hmm.
bringing nuggets and insights like that can really help to ensure that you can't afford not to prioritize on this budget. So
Right.
I think the biggest part is either they lump NPs and PAs together if you're doing a prescribing
Mm-hmm.
um, program, which they'll call, I mean, the right terminology, if you're going to say it, is advanced practice provider, or just
Mm-hmm.
say nurse practitioner or physician assistant. But a lot of times they'll, kind of lump them together and then use the physician materials. But budget is probably the bigger one.
Yeah. Okay, that's helpful. Thank you.
It's trading on received wisdom, right? It's like it's the old you never get fired for buying IBM kind of stuff, which Sanika, you might be too young to actually have ever heard that, but that was something that they used to say, right? Like, well, when in doubt, you never get fired for buying IBM. Now you would be, right? But that kept IBM afloat for a long time, well past its sell-by date, as it were. And I think, like, look, nurses are nice to have. We really need to focus on the doctors. I think people are stuck in the 70s, frankly, when they say that. Like, that's how dated that sounds to me, because nurses have been an integral part to how modern medicine works. Modern medicine is incredibly complex. And, I think the last sort of point I'll make, and Lisa brought it up, I say it all the time, medicine today is a team sport. There's very, very few things that are not team sport oriented. And I think, nurses are the ones who are really trained to be team players. I think sometimes clinicians can struggle with that. Not clinicians, doctors specifically can struggle with that. And that is something that I think the rest of the medical community can learn from nurses, right? Like, this is about the patient. It's not about your fiefdom or your expertise. It's about the patient. And that's what I think nurses really bring to the table, is they keep the patient firmly in view throughout. And so I'm the biggest fan of nurses. If you don't know it, I think you should know it. The entire medical edifice would crumble tomorrow if nurses went on strike. So let's do everything we can to make the nurses as happy as possible and give them what they need for their jobs. And then, Lisa, I just want to thank you again for coming on. And I'm going to give you the mic for any sort of last thoughts about, let's in praise of nurses, but what are your last thoughts?
Yeah, no. First of all, thank you so much for having me. I'm such a fan of this podcast, so I feel like, oh, I get to be on here. And then to also, recognize nurses. It's a great profession. Thank all the nurses out there that, work so hard and put patients first. They really do care. And, just next time you see a nurse, be kind.
Lisa, thank you so much. Again, if you have any questions about nurses or nursing, Lisa Chebanian is the go-to resource at Havas that I'm aware of for all questions nursing. But, to nurses everywhere, thank you for all that you do. And to wrap up episode 31, I'm Brad Davidson.
I'm Sonika Garcia.
And this is Breaking the Code.
Yes. Thank you, Lisa.
Thank you.
Bye, everyone.
Breaking the Code is a podcast created and produced by Havas Health and U's Medical Anthropology Department. Hosted by Brad Davidson and Sonika Garcia. Content and post-production audio editing done by Gabriel Allen Cummings. And inspiration from all of you. Thank you for listening and for your continued support. If you enjoy these episodes, we would love to hear from you. Please leave a rating, subscribe, and send us a message to our mailbox at medicalanthropology@havas.com. Until next time.